Thank you, Esther, and thank you all for inviting me to speak about these nice products. I said it's very easy for me to speak about things that I like. So you will see it's not just a wire and just another catheter. It's really something different to that what we normally used. And when I started using Asahi products, I wasn't aware of how correct and how positive this will be, and my experience will increase over time. And I have to say, I really almost, when I can avoid, don't use any other wires anymore. So it became really something very special. So I don't want to talk too much about the products itself, because I think I will go through it, but I will show you the different devices. But you can read and you can have all these product brochures. I just want to tell you about my personal experience and what I think is so important and what I appreciate in the products. Yeah, the challenging anatomies in aneurysms sometimes give us really hard times to treat these aneurysms, and that's why we need products that help us to overcome these obstacles. And when you find something like that, I think Chikai wires and Fubuki catheters is really something that my experience with treating these difficult cases became much more easy and more reliable. So I would like to share a few tips that I found how to use these kind of devices. And thank you for saying 10 years experience. It seems to me very long, but if I wouldn't have had the chance from my distributor, my Austrian distributor, that he offered me a wire that the cardiologists already used, I maybe never would have this long experience already. So thank you, Kurt, if you're hearing that, for doing this, and thank you, Asahi, for producing these nice products. I would like to start showing you the wires. I think you all know that since 2010, the Chikai wires are available. But in Europe, I would say in 2014, the first ones came in. And that's why I'm so happy that I use it almost since then. And I use mainly, I have to say that, the Chikai 14, yeah, the Chikai 10 also, and 8 for AVMs, but for aneurysms that we speak about is the Chikai 14. I go to the family. The nice thing is that you have two different options. These are the plain ones with the like 10 and 8, and the black. The black has a polymer coating or a polymer surface, which has different indications. I will come to that. And I think it's very important when you have Chikai wires that you really see the difference, experience the difference with your own cases to see what is better for your daily practice. Yeah? I will go a little bit to that. This technology, it's called Act 1 technology. Is something that I haven't experienced in other wires. It's the torque transmission and the durability of this technique is that what is so unique in the wires. You have a very accurate torque transmission once the wire is shaped, and a very reliable tactical feedback. I think this is so important. When you shape a wire, when it's outside of the body, you see exactly with your fingers what you're doing. Inside of the head, what is moving, and the wire is really one-to-one torquing. And one of the most important parts, it keeps the shape. I think this is my personal best feature on these wires. So why does it do that? As you see, it's called a working horse guide wire. I think this is exactly the thing it is. We use a lot of 10 wires in aneurysm treatments, but it turned out the larger the also these Alexis catheters and all these things get in aneurysm treatment, we are even more relied on 14 wires with the microcatheters because we have more support, but we need the softness of the tips. And this is exactly what you see here. You have this spring coil in the in the normal ones, not the black ones. And here you see really nicely how it's built. I would say that the first 5 centimeters are radio pack, which is very important. And it is also a marker for me to bring these 5 centimeters around the curve when it's difficult to pass the curve. Because this is then I know I can get around the curve. Because if you don't do that, it's sometimes very, very difficult to have a stable position in a very tortuous vessel anatomy. And I think this is a very good distance to bring it beyond the point you want to cross, and then bring your microcatheter around the Chikai wire. And when I go to these differences between the black one and the so-called normal spring coil, you can see that the spring coil wire has this hydrophilic coating, as well as the black Chikai, but the black has also a polymer jacket, and that means that the surface is even smoother. So in ADMs, for example, and the smaller sizes, I personally like the black much more because it's very, very smooth, very tiny, very, very quick torque is possible, yeah, has almost no friction in any kind of catheter. But in my opinion, it has also a lower stability for delivery. But I think it's just marginal to say these differences. But if you need the stability for delivery and the tactile feedback, I use the spring coil technology wire, also the normal Chikai 14. Why was it called working horse? So it seems to be that Chikai wire 14 was one of the most sold, or the one that is used mostly in all around the world, because this is the only wire where 14 is not mentioned on the package. So in the beginning, I always complained till I realized that this is the Chikai wire. The Chikai wire per se is the 14. So why do you need to put that on the label or on the box outside? So if you find one without anything, it's always the 14, the working horse. Just to let you know. So don't look for that. Maybe it comes sometimes, but it's no need because this is the one that everybody has. Yeah, that's the two different things. I think one very, very unique design here is also the round core tip. I think this is very important for the shape of the guide wire, because a guide wire which doesn't hold the shape is not worth anything. So yes, you can shape every kind of micro wire, but sometimes it's very, very annoying when you do work a few minutes and then the shape is gone and you have a straight wire again. So you need to get it out and shape it again. And here, the technology with the round core tip, I didn't know that this differences is, because with the free eye you don't see that. But you realize it when you start shaping the wire. It's a little more difficult to shape than a normal wire when you use a synchrotraxes or all these kind of wires. When you shape a Chikai, it is a little more effort necessary to do that. Yeah, it's good to use these stainless steel mandrels that come with it. Yeah, but I do it with my fingers. But it's a little more effort necessary to get this shape. But once it's there, it's really lasting, and it always keeps the shape that you gave it from the beginning on. And I think this is also one of the things what I like on the wire. I can rely on the shape, even if you work longer, have a lot of curves or different anatomies that allow this, the shape that you give it, it holds. You can see that here it is stainless steel with a high durability, and in the upper part of the image you see how the shape looks like, even if you I wouldn't say like destroy it, but sometimes these things happen when we do maneuvers in the patients. Yeah, and then in the other wires, usually you just need to take a new one. Yeah. I think it's against the policy to sell more wires, but this is one thing. But the real I would say, benefit about is it's always a real tragedy when you have to take a wire out and take a new one again to get up to the point where you already have been. This could sometimes lower a procedure, not only minutes, but maybe half an hour if you lose your position. So it's very nice if the shape stays as it is. And as I said, this is one of the major points that I like on these kind of wires. When I go to the guiding catheters, I think everybody has his preferred guiding catheter and what you're used to, you use all the time. And even during the night when you have a stroke case, you are happy to use what you're familiar with. And I am the same. I always use things that I'm familiar with, but sometimes you struggle. And when you have, especially in stroke patients, they are older and have more complicated anatomies, it's not so easy to overcome arch sometimes. And then you have your diagnostic catheter already in the common carotid. You take your 8 French guide up there, and then the whole system comes down because the 8 French is so stiff that you cannot move upwards. And that is what I learned with the Fubuki when I used it the first time. It has a very, very flexible tip, but a very, very stable segment below the arch or across the arch. So when you have your distal access or your diagnostic catheter across the arch in the common carotid or even farther, it is really much more easier to bring a Fubuki catheter around these curves, and the diagnostic catheter doesn't get pushed out of the carotid. I think this is something which really, I think once you have experienced that, you think, okay, it was difficult with the other one, but it was now easy. Let's try again, and then you do it again. You need a 130 centimeter for a 90 Fubuki. I think this is evident for all the other catheters too. But once you have done that and see how easy it is to get it across, even in a very, very difficult anatomy, you know what I mean. So the flexible tip with the hydrophilic polymer coating gives you this chance to really, really have easy access to the distal vessels, but with a very nice and stiff support that you need for difficult cases in the lower parts. I don't know who built that, but however it was done, it was excellent mixture of softness and supportive shaft. As you can see here, this is exactly what I mean. You have a very high backup in the aortic arch, but a smooth trackability when you introduce it across the arch. Yeah? I think this is exactly what I wanted to tell you before. Kink resistance is obvious that this is necessary, and this is for sure here the case. The good thing is there is different lengths available and different French sizes. So you have 6, 7, 8, and I think the hydrophilic coating is in the 6 and 7, 15 centimeters, and in the 8, 5 centimeters. This is also, I think, very important to know and to realize, because the 8 French is always used with a nice inner catheter that gives you a lot of support. So there is maybe not need for 15 centimeters. But in the smaller ones, when you also go to vertebral artery or so, I would take a 6 better than an 8. I think the 15 centimeters are even better and easier to use. The usable length is from 80 to 110. That is what you prefer in your patients. And sometimes you need a 110 because of the really bad anatomy in older patients. You lose your whole system in the aorta already and don't have enough support then in the carotid. So the 110 is very beneficial also. Let's see the inner diameter. I think this is always in the larger guiding catheters or in the smaller ones, whatever you want to do. You want to use 2 microcatheters or a balloon and a microcatheter, or a larger for a stent and a smaller microcatheter for coils or for any other devices. it's very, very important to still have the opportunity to bring enough contrast through the guide catheter to have a good position, a good visibility of your vasculature in the brain. And without that, you cannot do anything. Yeah, you're blind. And so I think it's very important to choose the right catheter for that, what you do. But even the 6 French with the 0.71 inner diameter is a very large catheter that gives you the opportunity to use 2 microcatheters and get still enough contrast through to have a good roadmap or diagnostic possibility with the contrast. And I personally, and you will see when I show you my cases, whenever I can, I use an 8 French because then I have all options. It is in former times we used 5 French and 6 French maximum. Nobody wanted to use that. But since we do all the stroke cases with the large bore catheters and the distal access, you anyway need a larger inner diameter and a larger also French catheter to support all this. And with the 8 French, I have to say it's a very, very stable platform, a very stable position. Once I have positioned my 8 French in the carotid, the case is almost done. And I had multiple times the issue that you either have a very, very stiff guide catheter, which causes a lot of vasospasm or even dissections in carotids, or on the other hand, it's pushed out of the system. So you need a soft system with a stable position, and this is what I personally can get with the 8 French in the anterior circulation, and usually with a 6 or 7, depending on what you want to use. Additionally, in the posterior circulation, and let's go to the cases. I think this is always the easiest way to show what I have done. And as we said, we speak about aneurysms, and most of that is done in the last years with all the devices. We use almost everything what is on the market. So this is a case with a patient she presented with ophthalmoplegia, had a therapy with steroids and an improvement of the symptoms. So we didn't treat her immediately, but we saw this incidental aneurysm 5 by 5. It wasn't the first priority to treat her immediately. Yeah? So we scheduled her for a treatment 6 days later, and as you can see, she had a huge enlargement of this. This was a pseudoaneurysm, and here I used a chaperone, which I wouldn't have done anymore when I would do the case again, because this was headway 27 and the Asai wire. The headway was pushing the contour out of the, I would say, the aneurysm very easily. And the chaperone is, in my opinion, also a very good catheter, but it gets pushed back in the carotid. So I really, really would have loved to have a Fubuki here in this case. And that's why I show you the case, not because I didn't use it, but because I would have better used it here. And these are the typical cases when you not try to get into the aneurysm. That's why I use the contour here, because whatever you put into a pseudoaneurysm, coils, intrasaccular devices might migrate into the supraphrenoid space. So you need a device that really sits in the neck of the aneurysm, hopefully without a stent option, because here I wouldn't, she needs her PCOM. I didn't want to risk that with a further verting stent here to cause any troubles with that. So an intrasaccular device was perfect. But the contour gives you, in this kind of position, always the hard time to push your guide catheter back. So as you can see, I don't know if you see that here, I don't know, there was a smaller section even from the manipulation at the final end. But the case itself went very nice. So you have here a 12 months follow-up. You can see that the aneurysm is completely gone. Everything has resolved. But yeah, you need good support for these kind of cases and good help of all, I would say, devices that you use, and especially the access devices, not only the devices to treat the aneurysm. Because when you don't have a good access, the best devices cannot help or cannot occlude the artery if you don't reach the point where you need to go. So this is another patient with a ACOM aneurysm. It was growing over time. It was now 7 to 6. It is a question if you could have treated it earlier, no doubt about it. But when you have a 7 to 6 ACOM aneurysm, I would not hesitate to treat aneurysms in this size. Here we used a good access catheter, a Fubuki 8, had a small, nice distal access catheter Phenom Plus, and as you see here, a headway 21 and a Asai wire. So Phenom Plus is a very small 4-French distal access catheter, which gives you excellent support. And with the Fubuki 8 French, I have really good stability. And in comparison to the other case, this was a very nice and easy case to be done, because I had a complete stable guide catheter there, and the 7 contour could be placed, as you can see here, very nicely in the aneurysm. You see almost immediate, I don't know if you see my mouse, but here you see the device. There is already almost complete occlusion when you position it. This is the lateral view. And this is 12 months follow-up. Here was the aneurysm. The marker of the device is always in the parent artery, which needs to be like that. Otherwise, you cannot occlude it. But you need to position it like that. And that is the difficulty in most of these devices. You need to position them correctly. And if you don't have a stable position of your guiding system and your guide catheter and the wires, this is exactly the problem, to position these kind of devices at the point where you need it. And you need to have the marker there. Once it's too far in the aneurysm, you might not occlude the aneurysm. If it's too far out in the parent artery, you'll have troubles in the parent artery, maybe with thromboembolic complications or even occlusion. So this is the 24 months follow-up of this case. I think it's also very nice. We do a lot of DynaCTs to avoid angiography all the time for the patients, which they appreciate. And we see very nicely that the aneurysms are occluded. So this is a very small aneurysm here, and then even more small on the right side. They have bilateral aneurysms, and the patient has, that's why I want to show you that, this really, really painful anatomy. Yeah? Unfortunately, here you cannot see it, but it was almost the same on the other side. So when you see that, you say, do we really need to treat this kind of aneurysm? Because it's very, very difficult to overcome that, and it's very difficult to get good support and good stable access. So this is the aneurysm. Again, I used my standard menu, I would say. I used the Fubuki 8 French, Phenom Plus and Headway, and the Asai 14 wire to access. Here, again, this is also a contour case, I see. It's, again, the same thing. Why I choose here a contour is because the access is straight here, and the aneurysm is outside of the middle, outside of the typical bifurcation, yeah? Usually the aneurysm should be here, but it's on the more or less A2 that sits on the side. So it's not so easy to access with for example, a web or any other device, this kind of aneurysms. But with the contour, you can position it here, except you don't have a stable access. You need to have a stable access to go there. And I only can say this is the most reason why I'm always happy to have a Fubuki and the Asai guide wire. I cannot repeat it more than often. So here you see it much better in the control. It's not in the middle of the artery, it's on the side branch, yeah? And it's really not easy to get a good position here. You need a very, very stable access. And a good result after 12 months here. This is also an aneurysm which It's a basilar tip, which is not so specific, but the access in this aneurysm almost took me maybe not an hour, but almost an hour. Yeah, it was really, really tough to get over the arch, to get over into the posterior circulation. You see, the right side is very small, so you had to go to the left, and it wasn't easy to overcome the tortuosity in the left side. But we took here a 6 French Fubuki and also a rebar, because the rebar is the catheter that we use for intrasaccular device RTs. And here I remember that so good, because when I started doing that, it was one of my first cases of RTs. I told the people, if this RTs pushes my catheter out of the aneurysm, I will not use the device. It did not. So the stable access and the device together in a very difficult anatomy gave me the option just to put it in, put it into the aneurysm, and you see immediately stasis, which is nice. That is what you want to see. But it's also a device that you have to position in the parent artery with the marker. This is very important. And to be that precise, again, you need a stable position. Here you see an 8-month follow-up. This is also a nice dynacity. When you see an empty device in the dynacity, it's occluded. So this one is a very tiny one. And this was an incidental finding. And normally I would say I don't treat this kind of small aneurysms, but sometimes when there is a history, family history, multiple things that sometimes force us to do that. Yeah, people have operations scheduled. Anesthesiology doesn't treat I don't know, whatever minor operation because of a brain aneurysm. So they have a lot of pain and get not operated just because they have no treatment of these kind of aneurysms. So also here, I decided finally to use something that is with less, I would say, impact to the patient at all. Obviously, you can operate an MCA aneurysm, no doubt about that. But also here, if you have a good access, a stable access, a good system, again with a Fubuki 8 French, which gives you the stability over the arch, distal access catheter, and even the old rebar 17, which is recommended for an RTs, works here perfectly because there is not so much space between the distal access catheter and the aneurysm. So you have a good opportunity to get not pushed out of the aneurysm, drop the intrasaccular device in, and have a very nice, stable, long-term result. Once it's in, it's done. Yeah, this is something, and it occludes, and you have stasis. I think I like these kind of devices because no dual antiplatelets are necessary for these kind of patients. Another one here, another asymmetric. Yeah, I think this is also important to know, because the straightforward ones are treatable with everything. You can use whatever you want to, but the ones that are outside of the symmetry of a vessel bifurcation are always difficult to treat. So here we have this small distal access, distal MCA aneurysm, and it's only 3.3 by 4.3. And you can coil it, but we know exactly that these coiled aneurysms reoccur. So again, I choose an RTs here. And what we do in these cases, we use Siemens size to help selecting the right size of the device. So again, you see I have used the Fubuki and an Asahi wire. This is really already boring for you maybe that you see what I'm doing, but this is exactly what I always use. And having these kind of help with the Siemens size, you always can choose one bigger, one smaller, and when you see the reconstruction in the software, you finally have exactly just one small attempt and drop the device and it's done. You don't need to have, oh, maybe I tried a smaller one. It's too small, I have to take it out. Or you take the too large one and risk rupturing the aneurysm. It's a good thing to have this kind of additional safety that you can play around. You shouldn't rely on the software as usual. We all know that, but it's a really nice help to have an additional help to the normal sizing charts that you have with all these devices. This is also a strange aneurysm where the patient presented with double vision since a few hours. So this was a typically acutely ruptured aneurysm with this extra, I would say, pseudoaneurysm on top. Here you have an irregularly configured aneurysm with 7 millimeters, and as it was acutely ruptured, but the patient was not suffering a subarachnoid hemorrhage. I think this is very important to tell you, otherwise you might not choose a stent here. And he had also, in addition, a NACOM aneurysm. I don't know if you see it. Yeah, here you can see it. There is also a small one. Obviously, we did not decide to treat this one, but we treated the symptomatic aneurysm here. And also here, I think the anatomy allows a good access, but it's not so easy to get here around all these curves without a good, again, stable access point across the arch, across the carotid. And here I used the Sophia as a distal access catheter and a Phenom Plus for a pipeline. And this was a good case for a flow diverter, I think. Why a flow diverter? I think here the whole vessel is diseased, and putting an intrasaccular device here, I don't know if the disease is not extending here or here across the aneurysm neck. So that is why in these kind of cases, when I'm not sure that it's only the aneurysm which is the not healthy part of the vessel, I always use a flow diverter. So the indication for that is vessel disease more than just the aneurysm. And obviously it's the typical location also for flow diverters. Again, an 8 French Fubuki gives you a nice support and a nice possibility to have controls with the contrast medium and Chikai wire 14. Procedure time, as I showed you, was 40 minutes from really bringing the patient on the table, puncturing and taking from the table. I think that is exactly what you want to have. When you lose a lot of time with access and have already troubles to access the I would say the parent artery, say it's the carotid or the vertebral artery, whatever it is, you have a lot of more possibilities for thromboembolic complications, for any kind of vasospasm, dissection in the access or whatever. So that's why I think it's important. It's the same important to choose the access products correctly as it's the same important to choose the right devices to occlude the aneurysm. There is no doubt that both needs to be perfect. If you don't have a good access, you don't treat the aneurysm easy and well, and you have a lot of more complications then. So this is post-deployment. Stent is very well placed, almost gone already. And at the final end, it was, I think we had a 1 year follow-up of this, unfortunately. Sorry, I didn't show it here. Yeah, these are the nightmare aneurysms. I think everybody has seen that in his own series, Who Treats Aneurysm. It is an incidental finding, but I think we need to treat those kind of. She's 43 years old, and you wouldn't like to leave patients with these kind of aneurysms. But we all know whatever we do, it's not easy. And as you can see here, I decided to use, I did that with a colleague of mine, and she did a really good job here in this case, because it was really, really not easy to get around all these curves with this long stent. What should I say again? You need a good access. With a Fubuki, we had a stable access, and even then it's not so easy to get there. But using an Asai wire, you overcome the curve around the aneurysm, because in these kind of aneurysms, you sometimes go into the aneurysm, make the curve across in the aneurysm, and take the exit of the aneurysm to access the distal vessel, which can be done, no doubt, but it's always a danger. And if you can avoid that, it's always nicer. And as I told you before, the shape of the Asai wire is not easy to perform, but once you have a good shape that is according to anatomy, and this is one of the things most of the people don't pay attention to that. But if you have the right shape of your micro wire, you easily can access, but you much easier can access a curve around a vessel than when you don't have the right shape. But then the micro wire needs to keep the shape, and that is the good thing on these Asai wires. So really a tough case, but well treated. Another nightmare aneurysm. She had more or less only pain and sensory loss in the face. Yeah, but again, this ugly aneurysm needs to get rid of. I think you cannot leave a patient with that in the normal. I would say she's 70 years old. Yeah, but when this ruptures, you can say these don't rupture. But if you look at the surface of these kind of aneurysms, it has multiple lobes, multiple irregularities. So when it ruptures, that's the end of the story, I think. Yeah, so you always try to put a very low risk option to the patient and discuss very heavily which kind of indication is the right one. But this is obviously a stent case. And here, again, you see how difficult it is to get around this anatomy. And we already produced vasospasm here and here. But to get around this aneurysm, if you don't have stable access and a good shape of the wire, you never ever end up in the distal part, distally to the aneurysm. So again, here we use the Fubuki and the Phenum and a pipeline in this case also for treatment finally. And this was after the treatment, immediate stasis with the long stent. These stenosis that you see here was there before. I don't know if you realized it before. I should have mentioned it. But fortunately, it didn't worsen. And this is one of the cases. My last case that I want to show you is a completely different topic, where it's also very important, and it becomes more and more, I would say, I wouldn't say modern, but more and more easier to access venous approach to therapies that we didn't treat before. I wouldn't say it like that. Intracranial hypertension and tinnitus is something that we didn't treat at all, I would say. Yeah, we treated them with medication, and we did in the past some rare cases of venous stenting in these kind of patients, but not routinely. Now, I think venous access is very, very more scientifically viewed at and also approached, and also the devices and the access products that we have are designed for venous approach. And here it's also very good to know that you can do that. These are so rewarding procedures. If someone has intracranial hypertension, especially young women, they really suffer. And the same is with pulsatile tinnitus patients. They suffer. Nobody can offer them a really good therapy. So if you find a stenosis, a venous stenosis like here, this is the best what you can tell the patient. So is it we have a reason? It seems we have a reason. It's maybe not always 100%, but in most of the cases, when you see something like that, you have a nice option to treat. And here you also can use the Fubuki in the venous system, as it is so soft in the distal part. In a vein, you need to be even more careful not to destroy it, because it's obviously much less resistant. But the Fubuki itself has such a nice soft distal tip that you can even here put it very far into the venous system. And in this case, I used the pipeline because the anatomy was allowing me from 6 millimeters. Then usually we use an 8, but here a 6 was perfect. And the patient, when she woke up, very nice stenting here, stenosis is gone. When she woke up, she shocked me because I asked her, "How are you?" And she said, "I cannot hear something. I cannot hear something." And I said, "What? You cannot hear something?" It turned out that the tinnitus was gone. Yeah, so I really couldn't believe it, that it's so quick, and it stayed like that. It's a really long time ago, and she never suffered again. And the hypertension also diminished, and we could put her off medication already. So just a brief conclusion. As you see, it's a little boring. Once you like the devices, you don't give them away anymore. The Asai wires, just to say, it's more effort to shape, but if you shape it correctly, it has a very, very high shape retention and accurate torque. And I think this, when you will see when you try it, you never give it away anymore. And the Fubuki guiding catheters are, in my opinion, the softest in the tip, but the most strong support that you can get in these kind of patients over the arch and in the aorta. I think this is a combination that is not always the case. Sometimes it's too strong and you have too much support. You have a higher chance of vasospasm distally. And you have a very large inner lumen. I think this is also something that gives me a lot of options here. Yeah, again, the most important is these kind of things allow you a very quick, perfect and safe access, even in difficult anatomies. Thank you. And if you have any questions, please feel free to ask me.